renal calculi or kidney stones. Kidney stones or renal calculi are little stones that develop in the kidneys because of increased uric acid or also increased calcium oxalate. Okay, it's an increased incidence in men. With this, you normally get nausea and vomiting. Women can get it as well. The really distinct figure with this is agonizing flank pain or side pain that radiates to the groin, testicle, and abdominal area in men. It also is a sharp, severe, sudden pain and may be intermittent, which means it comes and goes depending on how the stone moves. Okay. Classic symptoms you'll see is blood in the urine, also difficulty urinating, and also increased frequency as well of the urge to go. Sometimes in women, though, if pregnant women get a kidney stone, it's not really much we can do for it, but wait till it passes and then treat maybe with Tylenol and also fluids. Main treatment for kidney stones is you want to strain all urine and also treat for or monitor for pain. Okay, and so basically we look for that stone to pass. It's like a little brown crystal stone with sharp edges on the end. Okay. So individuals with recurrent stones or frequent stones, we may want to do renal stone analysis, also KUB, which is an X-ray, and then blood levels of calcium oxalate and uric acid as well. So what we want to do is make sure also teaching for individuals who get recurrent stones is increase fluid intake. Also, you want to make sure that they're emptying their bladder often. And then also making sure to stay fluid, make sure they stay well hydrated as well. So main things for kidney stones, monitor for pain, and then also strain all urine. Ureterostomies, ileoconduits, and ureter sigmoid ostomies. So I don't know if any of you have ever seen a urostomy in clinical. I know you've probably seen a lot of colostomies, but urostomy is just a creation of a diversion of the bladder. So sometimes individuals who may have had bladder cancer usually has to have what's called a urinary diversion, where they have urine that comes through the abdominal wall and it attaches to and it goes into a bag just like a colostomy. Okay, couple of things with this image disturbance. It's a dignity issue. So we want to make sure that individuals who've gone through this, that we're offering them an opportunity to express themselves and also monitoring whether or not they are adapting to this change. Nursing care, you want to make sure that you're looking at the skin surrounding the stoma. The stoma should be nice and pink. Because urine is so acidic, we want to monitor also for skin breakdown and make sure that the area is clean and dry always. The next two disorders we'll talk about are glomerulonephritis and also nephrotic syndrome, which are both immunotic kidney disorders. The first one we'll talk about is glomerulonephritis. It usually follows of what we call a strep infection, and that's very, very important. Normally, if individuals have strep throat 2 weeks prior to developing glomerulonephritis, they'll notice that this is what it was related to. Glomerulonephritis is an antigen antibody complex, and again, it comes from recent strep infection. What it does is causes a decrease in the glomerular filtration rate and also increase infection. And so the glomerulus, I think we talked about last Friday when we were in class, the glomerulus is a filter. And normally if the glomerulus isn't filtering, I asked you guys what the urine would look like. And of course, you guys said it would be really dark and maybe a Coca-Cola color. And that's just because there's not enough fluid going through there and it's not filtering properly. So what will this patient look like? The patient will have a headache, increased blood pressure, of course, because they're not decreasing, they are not letting off their fluid, so they have fluid retention. Also facial and orbital edema. They'll be very lethargic, and also weight gain, of course, because of the retention. Also, if you collect a urinalysis or do a urine dipstick, you'll notice there's protein in the urine, blood in the urine, and then they'll have what's called oliguria, which is scanty urine. You want to make sure that you remember that word because you might see it on your test, and I don't want you to be thrown off on that. Okay, so oliguria just means scanty urine or a small amount of urine output. And then also they have what's called dysuria, which is difficulty urinating as well. So what do we need to do? A couple of things we need to do for these patients. Number one, infection. So you want to make sure that they complete their course of antibiotics. Also, we want to make sure that we are giving them adequate fluid. And also for the weight gain or the retention, they may be also on diuretic therapy as well. And so then we have a question here. I have a client with acute glomerulonephritis. The nurse is caring for this client and anticipates the client will undergo treatment in order to prevent which of the following problems. Number one would be hypertension. Number two, hypothermia. 3, fluid volume excess, or 4, fluid volume deficit. And if you look at the signs and symptoms, you could get that answer easily. So you have small amount of urine output, urinary retention, and weight gain. So based on the choices we have, looks like the only obvious answer would be 3, which is fluid volume excess, which is excess amount of fluid. So if you said 3, you were correct. Nephrotic syndrome. So nephrotic syndrome is a condition where we have little urine output, but we have excessive amount of protein being released in the urine. Okay, and so because we have that excessive amount of protein, our albumin stores are low. Okay, albumin is a serum protein, a measure of serum protein. And so treatment for this is simply replacement of serum albumin, plasma albumin, and also increased stores of protein. The other thing that we will see because of nephrotic syndrome is salt and water retention, which also leads to edema, and also increase what we call aldosterone secretion, and also decreased renal function. So if we have decreased renal function based on what we learned before, you'll have an increased serum creat. So an increased serum creat, you'll see with this, also increased protein in the urine, proteins and fats. So nephrotic syndrome treatments. Number one, we want to make sure that we are treating edema appropriately. So monitoring I's and O's, also monitoring intake of protein, and also replacement of serum plasma albumin. In the hospital, if you were in an acute care setting, they would have IV serum plasma albumin running as well. So any questions about glomerulonephritis and also nephrotic syndrome, again, send them over to me. I'll welcome your questions. And yeah, so just email me. Very last slide for this lecture is prostate problems, which are specific to men. And so what you probably heard about or you known about is BPH, which is benign prostatic hypertrophy, or hyperplasia, which causes problems with urinary retention, also frequency, and also nocturia, where the man goes at night, has the urge to go to the bathroom at night. Also with this, you'll see blood in the urine, increased risk of infection, decreased urinary stream, and then increased urinary residual. And so with the post-void residual, you would notice in these patients that they avoid, but they'll still have a lot of urine left in the bladder, particularly for men. This is specific for men. So how do we treat this? A couple of things we do. Complementary therapies and teaching is what we'll start with first. So avoid overhydration. So limit fluid intake. Also limit alcohol and diuretic intake, and also caffeine. And then void as soon as they feel the urge. Some medication that you may have heard of, Flomax. You've probably seen that in clinical, or also Proscar as well. But if those are not successful in treating this problem, they'll do what's called a TURP procedure, which is a transurethral resection of the prostate. That is a day surgery procedure where the doctor goes in and relieves the obstruction. The really important thing to monitor for nurses with this is we do what's called a CBI, which is a complete bladder irrigation after this process, where the goal is to flush the prostate with normal saline, with the goal of eliminating clots that may be there because of surgery, post-op care. And so initially what the urine will look like is a really dark, bloody clots. But then after a couple of flushes, it would turn to light pink or clear, okay? And so with this, you have to be really careful that we maintain patency of the prostate, or else the doctor have to go back in and do this over again. So that is the final slide for the urinary chapter. So particularly our Monday group, you should be able to go through all of those and get everything you need for urinary. I will come back later and do lower GI and upper GI as well. Okay, so talk to you soon.